This first case is a patient who recently, several days ago, underwent a Whipple. So we can see the post-Whipple changes. So this is the remnant pancreas. This is the pancreaticojejunostomy. This is the suture line along the blind end of the jejunal loop. Here's the jejunal loop here. And there was all this kind of stranding and fluid and small foci of gas. You can see this is the region of the pancreaticojejunostomy. So any guesses as to what's going on here? Anastomotic leak. So Tammy says anastomotic leak, Rupa says contained leak, and Gitanjali says necrosis of omental patch. So one of those three is right. So anastomotic leak, that's always the thing that we are looking for after a Whipple. Usually the fluid might be closer to the pancreaticojejunostomy. There was a little bit of fluid up here, but most of this is centered separately from it. So we were not thinking that this was a PJ leak. And this was actually an infarcted omental pedicle flap. So I just wanted to talk about omental pedicle flaps for a minute. So this is just a diagram of the omentum. So this is the greater omentum is this peritoneal lining that's encases the stomach and kind of goes down. That's the greater omentum. And it joins with the lesser omentum and transverse mesocolon that wraps around the transverse colon. These pedicle flaps are basically used in multiple different surgeries. So this was my case. So in Whipple procedures, a number of surgeons use these pedicle flaps. Basically what they do is they cut a wedge of the omentum. The omentum is mostly fed by the gastroepiploic artery. So they'll cut a wedge of the omentum that's still fed by vascular supply here, and then they'll flip that into the Whipple bed. This helps with healing, and it also helps protect against PJ leaks. So if there is a leak, the omentum can soak up the juices faster, and it'll help the leak heal faster. And it also help prevent GDA stump leaks. So this is something they do frequently. We might not even see it unless the omentum infarcts. In this case, the theory behind why this might have infarcted is that this vascular supply was compromised in some way, and so this pedicle flap underwent necrosis. A couple of other points about this, which is that this is usually maybe causes subacute or mild pain. It's usually not. It's usually self-limited. It takes care of itself. You don't really have to do anything about it. The other question that came up in this case is, what does this gas mean? And we've seen several cases of this now, and I've put drains in some of them, and none of them have been infected. And so my theory is that if you have something that like acutely necroses, you can get gas in it. And I tried to find some evidence of this online, and mostly what I found was that if you see gas, for example, in pancreatic fat necrosis, that's a sign of infection. I really don't think this is a gas-forming infection here. So the only other examples I could find was, for example, after uterine fibroid embolization or after TACE, just due to the necrosis, fat is pulled in from like adjacent tissues, and air is pulled in from adjacent tissues, and it's just a sign of necrosis and not necessarily gas-forming infection. Any thoughts? Do you disagree? Agree? Okay, I have a couple of companion cases for the omentum. Actually, so another thing that they use omental flaps for is they can take the pedicle flap. So for example, that thin flap I was showing that they put up into the Whipple bed, they also can pull it down through and into the pelvis. And they'll use these pedicle flaps to help with healing and to provide like a space occupying area in the pelvis. So this is, for example, after an APR, they'll pull this pedicle flap down here. Again, if the vascular supply is compromised, this can lead to necrosis. And I'm just seeing the chat. Gitanjali said necrosis of omental patch. Yep. And Justin said whatever you said sounds good. Okay. And then one more interesting thing that I learned, which is that normally for gastric cancer, they will do a total omentectomy. This is because they're concerned that the gastric cancer spreads into the greater omentum. As you know, we often see nodularity and lymph nodes in the greater omentum. So in addition to resecting all of those lymph nodes, they usually resect the entire omentum. But now they're actually starting to try to preserve some of the omentum. So they'll do a partial omentectomy, and they'll kind of cut it off here. This is for maybe a more localized cancer where you don't want to lose the entire omentum. And again, this remaining omentum is going to be reliant upon the vascular supply that's preserved. So of course, this is also going to be at risk for infarction. Here's an example from the literature after partial gastrectomy. You can see this mottled fat-containing thing here. The important thing is you don't want to mistake this for peritoneal disease or recurrence. Especially in the immediate postoperative period, they can undergo necrosis, and then this should involute over time. So a couple more companion cases for the omentum. Here was a case of a young patient, and they had this kind of appearance of their fat. So the question came up to us, is this a liposarcoma of the omentum, or what is this? So any guesses? What would you guys have said or done? Do you think this is normal? In the end, we ended up biopsying this, and we also sent it off for MDM2, which is that marker for liposarcoma. And this just came back benign omentum with hypertrophy. So just one teaching point here is that the omentum can actually hypertrophy. It can mimic a fatty kind of mass lesion. Just know that this is possible. And if you need to biopsy it, send it for MDM2. This is another companion case. This was also a young patient. You can see they've got fluid, they've got peritoneal thickening and enhancement, and they've got induration of their omentum here. Sometimes this is tricky, and sometimes if you have a lot of ascites, you can have what looks like induration of the omentum, and it's not actual peritoneal disease. So in this case, we weren't sure. We didn't know why she had ascites. We thought this person was young. They had no other risk factors, no malignancy. We raised the possibility of tuberculosis, which can cause omental caking as well as ascites. But another clue here was how this bowel looked. You can see that it's kind of, it's got like even induration within the mesenteric fat. The bowel is hyper enhancing. It's kind of angulated. So when I see this now, I get very concerned that there's some kind of serosal disease on the bowel. This could be malignant. It could still be TB. We ended up doing cytology on the ascites. Cytology is not as good as doing an omental biopsy, and it came back signet ring cell cancer. Presumably from the stomach, although they never found the primary location. So just a very aggressive disease that had already spread into the omentum. How you get omental disease, it can be spread from direct spread, lymphatic spread, hematogenous spread, and then also peritoneal seeding. So for example, when you have ovarian cancer, and it spreads, it basically follows the flow of peritoneal fluid, and you'll get deposits on the peritoneum from just a flow of peritoneal fluid. And then just one final point about the omentum, you can do biopsies. So this was an example of omental, we thought caking, seeding, we wanted to do biopsies here. I found that FNAs are really ineffective, and you should just probably take a whole bunch of core biopsies. So in this case, we went to go do the biopsy. We looked like we were on a good track. And you can see by the next time our needle was there, the colon had already moved and peristalsed into our field of view. But we were still kind of at the edge of the colon here. And then without it moving our needle at all, our very next set of images, because I was getting a little bit concerned, looked like we were in the colon itself. And so my teaching point here is if I didn't move my needle at all, and that looks like I'm in it, and you can even see that there's kind of a divot here, it's actually that a lot of times the needle or the metal will kind of suck the colon or the bowel next to it, and it'll look like it's kind of surrounding the needle. So if you haven't moved your needle at all and it goes from looking totally fine to like suddenly looking like it's in bowel, it's probably sucked the bowel next to it and kind of wrapping around it. So anyway, we repositioned this and we ended up getting the omental caking biopsy, and this was also peritoneal disease. And then one final point is that some people talk about MRI for peritoneal disease, and on MRI, You want to look very carefully at the fat. For example, here we can see these like nodules of evil gray here. On post contrast, they tend to enhance the most on like more delayed imaging. For example, here. And then the real clue is on diffusion. They restrict diffusion. So always look very carefully at your diffusion. It could blend in with your bowel, but really out here in your peritoneum or in your omentum, you shouldn't see anything bright. Okay, any comments? Questions?